So this is a voided urine specimen from a 95-year-old male who was a former general, and he had a history of high-grade urothelial carcinoma in the urinary bladder, and this is his voided urine specimen. So we know the patient had a prior history. And so he had a history of papillary UC as well as flash CIS in the urinary bladder and the diverticulum. So in this specimen, first of all, we do see a lot of squamous cells, but because we know he is a male patient, not a female patient, and a lot of them seems to be enucleated. So this is more likely to be coming from the skin, possibly from the squam. Over the foreskin, and we do see scatter cells with increased size of the nucleus and increased NC ratio, a little bit polymorphism. So these cells do seems to be abnormal, and because of the history, I think this is consistent with high-grade urothelial carcinoma. The problem for this case is that the tumor cells are pretty scant. So likely these are from the CIS. So again, here we do see, if we compare the size of the nuclear, you see this is very different. And the cells show, in addition to enlarged nucleus, but also coarse chromatin and increased NC ratio. So these are consistent with high-grade urothelial carcinoma. So sometimes, especially for the CIS patient, the tumor cells will be quite scant. So in this case, it's relatively scant, but still we can see these unequivocal high-grade cells. So this is consistent with positive for high-grade urothelial carcinoma. So the next specimen is coming from a patient with a history of cholangiocarcinoma, and this is an ascites specimen. So cholangiocarcinoma is the primary adenocarcinoma arising from the bile duct. So this is with the morphology of typical carcinoma feature. We see tight three-dimensional cluster, and for this case, it does show high-grade nucleus atypia, along with some intraepithelial inflammatory cells. So for the single cell, we do see that this is a very big nucleus, very big nucleoli, and with a lot of bubble in the cytoplasm. So this is diagnostic for adenocarcinoma, and based on the history, consistent with cholangiocarcinoma. So the next specimen is a pleural effusion specimen. The patient had a history of lung adenocarcinoma. So just on medium power, we do see tight aggregations of the cells. And the cell do show typical morphologic feature of adenocarcinoma, again with irregularly coarse chromatin prominent nucleoli and the three-dimensional arrangement. So this is consistent with metastatic lung adenocarcinoma. So the next specimen is a pleural effusion specimen, 73-year-old male. So this specimen, on low power, we do not see aggregates of the cell. We only see the single cells. But the single cells do have a quite monotonous feature, and on this power, you can tell that the cells is a little bit bigger than the usual lymphocyte. So when we go to higher power, we can appreciate that if this is a mature reactive lymphocytes, so most of the cells in the specimen do show a much open chromatin, some with a few like two nucleoli, quite irregular, and it does show a quite monotonous appearance of these single cells. So the morphology, the cell do looks like lymphocyte, and it is atypical with a large cell feature. So this is consistent with lymphoma. So for the lymphoma, usually we would be easy to make the diagnosis if the cell is large, if it is a large cell lymphoma. So the patient has just been recently diagnosed, just at the same admission. He has been diagnosed with a diffuse large B-cell lymphoma in the lymph node. And this is consistent with the body cavity, like a pleural effusion involvement. So here again, we do see these cells are much bigger than the typical reactive cells. And for the loose stem preparation, we do see occasionally the quite prominent cytoplasmic basophilic rimming, suggests that this is lymphocytic origin. So the morphologic pattern is consistent with involvement of the patient's non-history of diffuse large B-cell lymphoma. So because the patient had a history, we don't need to do the immunohistochemistry. But if the patient do not have history, we will need to do CT20 and CD3 to confirm. So this is the specimen that we've seen a few weeks ago. That for the first specimen, we see the patient's ascitic fluid. So in the ascitic fluid, we do see quite prominent, like in the single ring cell morphology. And clinically, the patient in the CT scan, it does show irregularity and the thickening of the gastric wall. So originally, we think this is single ring cell carcinoma, and this is the ascitic specimen. And then we received the patient's pleural effusion specimen. So basically, it shows a very similar morphology, but less signaling ring cells. And most of the cells have this epithelioid morphology, and it's relatively uniform. So it's a little bit difficult to tell whether these are mesothelial cells or these are indeed metastatic tumor cells. So because the patient also had an image showing that there is a mass lesion in the breast, so we performed MOC31 as well as GATA3 in the cell block preparation. And for the GATA3, you can see over half of the cells are indeed diffusely positive. So this is more likely to be a breast cancer, and the patient received two endoscopic examination and the biopsy. In the two biopsy, there were no signaling cell carcinoma, despite there were like a very scattered cell do show this prominent signaling ring cell feature and with a mucin in the cytoplasm. So occasionally, lobular carcinoma can show this feature. So we do use the residual specimen from the ascites fluid to do a cell block. Again, scattered signaling cell. And we do perform a GATA3, which shows similar patterns. So basically, the patient came to our hospital with the initial presentation of abdominal fullness. And it turned out to be a metastatic lobular carcinoma from the breast in both the pleural effusion and the ascitic fluid. So I have to say the cytology for lobular carcinoma is very tricky because they are just very, very bland looking. So under no circumstances we would be highly suspicious that these are metastatic carcinoma. These are just very, very uniform, bland looking and small cell and without prominent nuclear TPR. So initially we identify these type of cell. These are definitely cancer cell because mesothelial cell won't show intracytoplasmic mucin. So this seems to be metastatic adenocarcinoma. But I just want to say for this type of specimen, we just first need to identify cell showing unequivocal feature of malignancy. And something unusual about this specimen is the uniformity, the monotonous appearance, and you do not see a significant component of either inflammatory cells or morphology suggests that this is histiocyte, like admixed with all these mesothelial cells. We just see very uniform morphology of these mesothelial looking cells. And then you should think about the possibility of poorly differentiated carcinoma. So lobular carcinoma is one of the challenge in the cytology, especially in the fluid cytology. And now we see occasionally for the lobular carcinoma, it does show secondary ring cell feature in the effusion cytology as well. So I think this is a good case that we can try to report this in our annual meeting because the first specimen is actually from the ascites. And the patient received biopsy yesterday, so we will see the result of the breast biopsy, but it should be a lobular carcinoma. So we have some other very unusual body fluid specimen. This is coming from a 33-year-old male. This is his pleura effusion specimen. So we have very scant cellular component. So on high power, a majority of the cells seems to be PMN inflammatory cells. So seems to be unremarkable. They were a few, here. They were a few area showing like a scattered atypical cells with relatively dark staining nucleus. Yeah, I have to say this is quite difficult. So first, the patient is very young, 33-year-old, so you wouldn't expect that he has something like metastatic carcinoma. This is very rare for the young patient. In the cell block preparation, so again, it is not very cellular, but we do see a few of these cells showing relatively increased size of the nucleus, a little bit like irregular nuclear membrane. The nucleus is not rounded. You show some of these cell-in-cell type of morphology pattern, and the cell do show very high NC ratio. So when we check the history, the patient had Ewing sarcoma. So he is a patient of Ewing sarcoma. So Ewing sarcoma is a tumor with a small round cell morphology that can mimic like a small cell carcinoma. So it does show the feature with like a molding type of pattern and more like a neuroendocrine type of chromatin pattern. So we do the immuno. For the Ewing sarcoma, we use NKX 2.2. Yeah, the cells were just too scant, so difficult to focus. So here we do see for these typical cell, it does show nuclear staining of NKS 2.2. So this is probably the first specimen that I see Ewing sarcoma metastasis to the pleura effusion. So this is very rare because rarely sarcoma will go to the pleura effusion. Next specimen, we've seen this specimen yesterday. So the patient is 80-something-year-old male with a history of prostate adenocarcinoma. This is his pleura effusion specimen. However, the cytomorphology of this adenocarcinoma is not compatible with the prostate cancer. For the prostate cancer, usually we will have a more uniform, rounded nuclear. This nuclear is way too big and a little bit irregular. So we were thinking that it could be a second primary lung adenocarcinoma. So we do TTF1 in the cell block. So the TTF1 is positive. So indeed, this is second primary. So nowadays, for our patient, it is very common to have 2 different tumors, sometimes even 3 different cancer. So this is NKS 3.1 for the prostate. The marker is negative, so you can see this is actually not metastasized from the prostate, but a new second primary of lung adenocarcinoma. And we already suspected based on the morphology. So another patient, 71-year-old male, this is a CT specimen, and this is a male patient. So again, I think this is a little bit similar to the to the lobular carcinoma that we see. Just on low power, it's kind of difficult to tell because we do not see aggregates of the cells. But we do see a relatively monotonous feature and some with like a signaling cell morphology. And additionally, we do see some of the cell is unequivocally malignant, such as this one. So we have a definite malignant cells. However, in the background, all these relatively bland-looking cells also seems to be quite abnormal. So for this specimen, it looks like a poorly differentiated adenocarcinoma in male patient in ascites fluid. So most likely coming from the GI tract. This is MOC31, a glandular cell marker that you can see majority of the cell are positive, suggesting that even the smaller cell are still metastatic adenocarcinoma. So again, this is probably from the stomach, but the patient again do a stomach biopsy, which is negative. So just based on these morphology, it's kind of difficult to tell where exactly it is coming from. It's just a quite poorly differentiated, like adenocarcinoma pattern. So the patient will still need to do some clinical survey, including like an image survey to check whether there's other primary tumor. So the next specimen, we move to final aspiration cytology. This is coming from a 41-year-old female. This is the direct smear. So in the direct smear, first of all, we do see a lot of blood in the background. We do not see a prominent colloid pattern, and this is very classic, a very nice complex papillary structure that we can see. It does show some fibrovascular cord with these spindle cells. Some of them were endothelial cells, some of them were fibroblasts, and they were epithelial cells lining around this complex structure. So this is a nice papillary structure. So when we see this background, no colloid, hypercellular, a lot of papillary structure, I think we always think about papillary thyroid carcinoma. So on low power, this is a classic case, highly suggests that it is papillary thyroid carcinoma. So the direct smear is relatively bloody. We move to the liquid-based cytology, and the blood will all wash out, and it's easier to see the nuclear feature sometimes. So here we do see a pseudo inclusion over here, and another nice pseudo inclusion in the center. So this is consistent with papillary thyroid carcinoma. So again, clean background, sometimes bloody. So in the direct smear, you will see more blood. In the liquid preparation, you can see some blood. Majority will wash out. The architecture pattern show complex papillary growth and also these monolayer sheets pattern. So this is a classic case for papillary thyroid carcinoma. And we will send this out as TBS category 6. So this is thyroid aspiration that we saw yesterday. It looks like it is not coming from the thyroid because the cells are just too high grade. And the patient had a history of lung squamous cell carcinoma. So we do immuno on this case. This is P40 squamous cell marker, so the nucleus were diffusely positive. And for TTF1, so we see the nucleus were all negative. So this is consistent with metastatic squamous cell carcinoma to the thyroid. So in the recent year, it's getting more and more common. We haven't seen that many metastatic cancer in our final aspiration cytology, but nowadays it's getting more and more common. So we move to pap smear. So this is a 66-year-old female who received hysterectomy due to there's no specification in the requisition sheet. However, I think she came to our hospital because of a positive pap smear at the outside hospital, suggests that they were a CIN3 lesion. So we realized that for this patient, she had already received total hysterectomy, so there should be usually no endocervical cells, no glandular cells in the pap smear. This is still relatively cellular, so we have a good population of cells for review. So the background is relatively clean. So the problem is occasionally we can see very scattered cells. So you see increased size of the nucleus, hyperchromasia, coarse chromatin. These seems to be a nucleated, naked nuclear. So a little bit difficult to interpret because sometimes in atrophy you can see individual like a naked nuclear with more hyperchromatic chromatin. But this one seems to be quite abnormal. But this is only a single cell over here. And here we have a more superficial cells. And this is relatively indistinct. You don't know whether these were binucleation or just one nucleus. So in the background, we do see very scattered cells, squamous cell, showing this atypical feature. However, just like we discussed before, usually for the high CO, the cells, the nuclear size are smaller than the low CO. So this cell looks kind of big. and kind of scattered. So for this case, I decided that I think they are definitely some dysplastic cells. So which means we do see precursor cells, but it is uncertain whether this is high CO or not. So in the old TBS, the second edition, I think there was a first or second edition, there was a category called low CO high. Low CO cannot exclude high CO. So in our own like a reporting system, we have a category called dysplasia cannot exclude high CO, which means that we think there were precursor lesion, but we are uncertain whether this is high CO or not. So we rarely use this category, but for this case, I think we can use this category for the report. So next case, 48-year-old female with a past history of low CO. And so this is a follow-up smear. So she is relatively young, and so we can see nice elements of endocervical cells. So we do have good sampling of the T-zone. And for this case, we do see very scattered cells with like a vague coilocytic morphology. And the cell does not show prominent hyperchromasia, and it does not show prominent increased size of the nucleus. The halo, it doesn't forming like a nice like a border. So for this case, I think this is qualified for ascus. And because the patient do have history of low CO, we have a few cells with this type of morphology. So these is fulfill the diagnosis of ascus. So we call this case as ascus. So that's for all the case today. Thank you.